Welcome to Let's Talk About It. Broadcasting live from North Nashville, Tennessee. North Nashville spans from Metro Center down to the border of Bicentennial Mall, including the neighborhoods of Bordeaux, Buena Vista, Parkwood Estates, Germantown, Haynes Manor, Jefferson Street, Fisk Park, Cumberland Gardens, Oak Valley, Enchanted Hill, and many others. It's perhaps best known for the 3 universities housed here, including Tennessee State University, Fisk University, and Meharry Medical College. North Nashville is also home to the Tennessee Titans practice facility. The Tennessee Titans will begin construction on an expansion project at St. Thomas Sports Park, which will almost double its current footprint in Nashville's Metro Center neighborhood. The plan includes 60,000 square feet in additions, including a new building situated along one of the practice fields, and major renovation of spaces within the existing 75,000 square foot building.
Now live from North Nashville, Dr. William Head. Let's talk about it.
Hey everybody, this is William Head for NorthNashvilleTV.com. Today we're at the Vanderbilt University Psychiatric Hospital talking to Dr. Paul Newhouse, who is the director of the area of cognitive medicine at the hospital. Dr. Newhouse?
Today's guest is Dr. Paul Newhouse. He is the Director Professor of Psychiatry and Pharmacology at the Center for Cognitive Medicine in the Department of Psychiatry at Vanderbilt University Medical Center. Dr. Newhouse received his undergraduate education at Kansas State University, attended medical school at Loyola University, Stritch School of Medicine, and completed his residency training in psychiatry at the Walter Reed Army Medical Center. He completed a fellowship in geriatric psychopharmacology at the National Institute of Mental Health. Dr. Newhouse's research has focused on central nicotinic mechanisms in degenerative brain disorders and the role of nicotinic receptor systems in normal and disordered cognitive functioning in humans. He has also focused attention on the development of novel nicotinic agents for clinical use. Another major focus includes studying the interaction of estrogen and central cholinergic, catecholaminergic, and serotonergic systems in relation to cognitive and emotional aging in the elderly and novel pharmacologic imaging methodologies. Other interests include treatment of depression and behavioral disturbances in the elderly, and development of effective novel agents for the treatment of neuropsychiatric disorders of the elderly. He is a diplomat of the American Board of Psychiatry and Neurology in both general psychiatry and geriatric psychiatry, and in 2002 was awarded the American Psychiatric Association Profiles in Courage Award. Dr. Newhouse serves as a frequent consultant to pharmaceutical and biotechnology companies in the United States and abroad on central nervous system drug development, clinical trial design for dementia and depression, and clinical nicotinic pharmacology. He has served on and has chaired numerous NIH grant review committees, and is an editorial board member and frequent reviewer for scientific journals for manuscripts on depression, dementia, and cognitive neuroscience.
Thank you very much, Dr. Head. It's a pleasure to meet you and a pleasure to be featured here today.
Appreciative of your greeting, and when you say doctor on my end, it's just EDD, an education degree. On your end, much more significant. The center here, when we talk about cognitive medicine, the first thing you think about when cognition is learning and retention and being able to regurgitate what you learn. In your case here at Vandy, tell us the function of your area.
So the concept of cognitive medicine is that medicine for the brain is basically about cognition as one of its major aspects, right? We can have motor function, such as how we walk or how we move our limbs, or sensory function, how we hear or see.
You say hear?
But cognitive medicine really is about what the brain does as its highest level, which is thinking, learning, remembering, speaking, making decisions. And so we believe that those disorders of higher level cognition is what we need to study and we need to develop treatments for.
It is, as an educator, I find that extremely interesting from the standpoint of teaching, how you have to teach people to develop the cognitive level of their thought and apply, putting it in a practical sense. So when you deal with an individual who said, like me, who can't hear, and they have difficulty learning, is that just a cognitive issue or a physical issue? Or
So we think it's both. When we think of patients with depression or with schizophrenia or with Alzheimer's disease, these are disorders of thinking. They're disorders of learning and memory and interpretation and making decisions and being logical. And those are all what we think of as higher level cognition. And so it's right. So when you think about a hearing deficit, what does that cause? That may be caused by a physical problem in the ears, but it also actually turns out to be related to brain mechanisms in areas of the cerebral cortex. And so one can investigate cognition at various different levels. Here in the Center for Cognitive Medicine, we're focused on particularly disorders of aging and age-related changes in cognitive functioning.
At my age, I understand exactly what you're talking about. Doc, you mentioned a word a moment ago, Alzheimer's, that is very big, and I want to get to your research and development in a minute. But explain to our listeners, viewers, the difference between memory loss and Alzheimer's.
Sure.
The difference between, what is it?
Dementia, memory
dementia
loss,
is what I
right.
was trying to find.
So, memory loss is something that we all experience. We all can forget things. We can become mildly forgetful. For most of us, that doesn't constitute a serious problem. But for patients with Alzheimer's disease or other dementing disorders or dementias, it can become progressive. And so, dementia is a sort of global term that incorporates Alzheimer's disease plus other diseases as well. And dementia means that it's more than just memory loss. It's affecting your ability to take care of yourself. It's affecting your ability to speak and use language. It may affect your ability to drive or to make decisions. So dementia is a sort of global problem. And Alzheimer's disease is the most common form of dementia, but it's by no means the only one.
Now, is dementia the exit? Alzheimer, the end of dementia, the distal end from reality, or?
Well, Alzheimer's disease is defined by two pathologies under the microscope. You have to see two different abnormalities under the microscope to define what Alzheimer's disease is. That's what our pathologist friends tell us. If I see plaques and tangles under the microscope, then that's what I define as Alzheimer's disease. But it turns out the aging brain, unfortunately, is also susceptible to other types of damage as well, vascular damage, blood vessel problems, and other abnormal protein buildup that can also create problems.
Well, in some brain injuries, the brain develops an alternate route for information that was once routed through a different part of the brain. I've heard that.
That's
Maybe.
correct.
And when you get to the point where you have dementia, have you now has the brain now lost the ability to reroute information, or is it a situation where it is grown to be so large that there's no way to do it?
Well, we know that there's that the brain is a flexible organ. It can, as you say, reroute, or it can actually engage other parts of the cortex to do a certain cognitive operation if part of the cortex isn't working the way it should. And that's good, but it has costs associated with it. So if I'm using more of my brain to do something that I could do before with less of my brain, then that costs energy, it is tiring, and it is slower.
Okay.
And so, the brain actually, if you look at brain scans while people with memory loss or dementia are doing a task, they will use more cortex than you or I would.
Okay.
And they may perform as well, but that comes with a big cost associated with it. And we can see that even with patients with head injuries. We can see it with people with strokes. Even things like cancer chemotherapy can produce this odd picture where you see more of the brain involved than really it should be. And that comes with added costs. We pay a price for that.
So that means if one portion of my brain is not operating at least a minimum level, then the rest of my brain is affected.
That's right. So a few days ago, I was talking with a young MD PhD student here who's working on implanted devices to improve seniors' hearing, right? These cochlear implant devices. And one of the interesting things that I learned from her is that the area of the brain that translates sound into language, the sort of what we call the primary auditory cortex, if you're hearing impaired for too long, the brain says, well, I'm not getting information there about my hearing, I'll just use that for other functions. And so your auditory cortex now gets maybe taken over by the vision system, and now it's hard to get that back. The brain says if it's not being used for this thing, I'm going to use it for that thing.
That's sort of like they say that people who lose their sight become very tactile in
That's right.
how they approach things.
That's right. So the sensory, so if you're blind, that part of your brain at the back, which is normally devoted to vision, might be taken over by other sensory organs. Exactly. Hearing, touch, those kinds of things. That's exactly right. The brain can rewire itself. That's a term we call plasticity. 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 And so
I need to use that in a conversation.
That's right.
Somebody will look at me and say, you're out of your mind. Go ahead.
Yeah. So we're actually very interested in neural plasticity. In fact, we're trying to take advantage of that in some of our work by either using drugs to improve plasticity or even brain training to take advantage of plasticity to help rewire the brain a little bit. So for example, for one of the studies that my young colleague, Dr. Alex Conley, is doing here in the center, is actually using a specific brain training program designed to improve what we call executive function, which is a product mostly of the frontal lobes of the brain, as a way to compensate for memory loss. And so we'll see if it works. We're taking a program that was developed by a colleague of mine at the University of Utah, who has Dr. Shizuko Morimoto, who has spent many years developing this strategy to improve seniors' cognitive function, particularly in seniors who suffer from depression. And what we're now doing in collaboration with her is trying to see if we can enhance that neuroplasticity in patients who actually are experiencing memory loss.
Getting back to Alzheimer's, I watched my mother go through it. Watched her as a very active person and very engaging, and become someone who was completely withdrawn into herself. As we look at loved ones deteriorate, is there any, well, I'm finally going to get to your research, is there any anything we can do to create comfort for them in that particular zone? I mean, we don't know what they want. They don't speak. My mother grunted, occasionally groaned, but to give her comfort, I had no idea what to do.
Right. Well, late stage dementia is a serious problem, and we do try to develop and help families and caregivers provide comfort, right? So our most important thing is to improve the quality of life, not the quantity of life. We are starting to make great strides at the beginning of Alzheimer's disease in trying to delay the progression of the illness. But the disease will inevitably progress. We haven't been able to develop a treatment to stop it yet. And many of physicians like myself and other professionals are focused on the later stages of life. So I have a colleague in South Carolina who is focusing on end-of-life care for patients with Alzheimer's disease and dementia, and he's actually exploring the use of cannabis derivatives to improve agitation and distress in patients with who are in hospice care for dementia. Now, again, we'll have to see if that's helpful. He has some small amounts of data, anecdotal data, as well as a colleague at the University of Toronto. She's been working also on developing cannabis derivatives to help alleviate distress. But you know, that is a major goal of our clinical work. And as a field, we're trying to develop better treatments for end-of-life care, for sure.
Now that gets us finally to the subject of the interview. Tell us about the research that you are currently doing right here.
So we have a program that really goes from prevention all the way to treatment. Alzheimer's disease is a multifaceted problem. So there's never going to be a single magic bullet for this. It involves changes that develop over many decades of life. We now have evidence that the changes in Alzheimer's disease really start probably 25 to 30 years before patients develop symptoms. And so we are engaged in several aspects of this. One is to identify who's at risk for developing dementia later in life. We have studies focused on identifying people who have no symptoms but have already the brain changes associated with Alzheimer's disease. Can we prevent them from ever developing the Alzheimer's disease? And then we have studies which focus on treating the memory loss and the cognitive impairment that we see with this. And so we're trying to hit all of these kinds of areas because we really have to, as my sports-oriented friends say, many shots on goal here to try to make a difference in this disease. So, for example, we have a study that focuses specifically on identifying risks for middle-aged and older women. We have an interest here in our laboratory that focuses on women particularly because we know that women are at higher risk for developing Alzheimer's disease as they progress through their life. We think there are biological reasons for this that relate to the differences between the sexes and relates to hormones. We think that that's not causing the Alzheimer's, but we think it actually adds sort of an additional risk factor. Then we have a major study that we're collaborating with people all around the country on, which is trying to identify people from about 55 to 80 in terms of identifying whether they have excess amounts of this abnormal protein in the brain that's associated with Alzheimer's disease. And the idea there is if we can pull that protein out of the brain, can that reduce their likelihood of ever progressing to having memory loss? So that's a true prevention study, what we would call secondary prevention. It's kind of like the same idea that if you go into your doctor's office and he tells you that you have elevated cholesterol and I'm going to put you on a drug that's going to reduce that cholesterol to prevent you from having heart disease, that's the same idea with what we're trying to do for Alzheimer's. We're trying to identify if you have too much of something that we can remove or reduce, can we prevent that disease from ever starting, that syndrome?
So is this a preventative thing?
That's exactly right.
So if you've already sort of gotten into dementia, will that be something that you would look to do maybe to slow down
Well,
the progression?
I'm getting to that, yeah.
Okay.
So the same treatment that we're using possibly for prevention is the drug that just got approved by the FDA recently for treatment of early Alzheimer's disease. And so we're trying to sort of, okay, we have this drug that can have some impact on patients with existing Alzheimer's disease. Can we back the clock up now and look before they ever developed any symptoms, but we know that that protein is in the brain and we want to remove it before it causes too much damage, before it starts this irreversible downhill slope. So that's another type of study we're doing, and that's the AHEAD study that we're recruiting people from the community. And then we have studies which are aimed at actually treating patients with memory loss. So we have one multi-center study that I direct, that's a national study, where we're trying to repurpose transdermal nicotine as a brain treatment, actually, where we can the drug we love to hate, and because we know I've been studying nicotine effects on the brain for most of my career, and we know that it actually stimulates certain brain circuits in a way that we think could be potentially useful if it's separated from tobacco. So we're now studying that.
Okay.
I direct a national study focused on that. It's called the MIND study, M-I-N-D. And then we have other studies that are involved in developing treatments for patients. We're repurposing other drugs. We're doing a study with a diabetes drug, which we think may have benefit for patients with Alzheimer's disease. And then we have totally new approaches. We're even looking to work with a Swiss company that's developing a vaccine that again hopes to remove abnormal proteins from the brain. So we have a lot of different approaches. Here at Vanderbilt, we also have a wonderful center that develops new drugs for the brain. It's called the Warren Center for Neuroscience Drug Discovery. And we've worked with them to develop new small molecules to stimulate brain circuits that are involved in memory, and we successfully tested first in human studies with that molecule a couple of years ago, and we've now out-licensed that to a company to further develop. And we're also collaborating with a group here at Vanderbilt that's developed another molecule derived from a natural substance that we think could actually reduce some of the inflammatory processes that come along with Alzheimer's disease. So we're taking this very multimodal approach to trying to understand where can we grab this elephant? We're trying to grab this very large elephant.
You can't take
in
it
varied
in
places.
one bite for sure. As you look at the progression of dementia on its way to Alzheimer's, sounds as though what you're trying to do is slow that traffic that's going toward Alzheimer's. Is that the removal or the slowing of the protein flow? Explain that to me.
So we know that amyloid, which is one of these abnormal proteins, is called amyloid, or more specifically beta amyloid, but we'll just call it amyloid. We know that all of our brains make amyloid, but most of us clear it without a problem. The problem for some of us, however, is that we either overproduce it, that's a rarer problem, or for most of us, we're not cleaning it up, it's accumulating. And if it accumulates beyond a certain point, it seems to initiate a whole negative cascade of effects, where a second abnormal protein starts to get deposited called tau protein, and actually maybe that second protein that does the worst damage. And so we know that the sequence runs amyloid first, tau second, and then there are a whole bunch of other abnormal proteins that can end up appearing. And so what we want to do, we think, the best strategy is to stop the first problem, and maybe then the second and third and fourth protein problems don't develop as much. And so we think it's a sequence of events that occurs in the Alzheimer brain that start way back here, years ago, and gradually build up without anyone knowing it. Right? So for example, if you're developing cholesterol in your coronary arteries in your heart, you don't know anything about that until suddenly you have a heart attack or you have a clot, right? There's nothing that tells you you're developing that cholesterol, excess cholesterol in your arteries until something bad happens. Well, that's a similar model for what's happening in the brain. You can build this protein up for many decades or years before you even know that you're starting to have memory loss. And so we want to prevent you from ever getting to that point of having memory loss, because by the time memory loss becomes obvious to people, there's already been a lot of brain damage. And we want to prevent people from getting to that point, ideally, right?
So by the time you get to the point where your memory is betraying you, you've already
had a lot of damage. Now we can't escape aging, right?
Oh,
I mean,
no.
none of us gets out of this alive, as far as I know.
Not at all. Not at all.
But one of my mentors said the goal of aging is to live long and die fast. Right?
Okay.
Live
Not
long,
suffer.
die fast.
Don't suffer.
Exactly. So you sort of want to go along and then suddenly go off the cliff, right? And that would be the ideal, is we want to retain our faculties right to the end, if we can. And so that's our goal here in the Center for Cognitive Medicine, is live long, die fast.
Okay. There are a lot of wives' tales about one helping oneself to keep away from dementia and Alzheimer's. You need to keep your brain stimulated. You need to this, that, and the other to manage that. People play word games, all that kind of stuff to stimulate cognitive abilities to keep them working. Is there any actual relationship to that type of approach, given what we've already talked about in the biochemical area?
The answer is there is developing evidence that those things can be very helpful. So we know, for example, that highly educated people have a lower risk of dementia, probably because it gives them more reserve in the brain, right? So they can lose more brain abilities and still be in that normal range, right? So higher education, or as much education as one can get, is always a good thing.
Everybody, go back to school.
Well, and there's actually benefit even in old age of learning new things.
Absolutely.
So there's very good studies that have been done where it's shown that if you actually stress your brain by learning new things, even as a senior, that actually protects you. So learning new challenges, new brain challenges are important. In other words, the brain is like a muscle. If you don't use it, you lose it. So you will lose abilities unless you are constantly challenging yourself. You know, if you remember Alice Through the Looking Glass, what did the Red Queen say? You have to run as fast as you can just to stay where you are. Right? And if you want to get anywhere, you got to run a lot faster than that.
A lot faster.
So, and that's true. So challenging ourselves mentally, even as seniors, seems to be particularly important. Now, you know, it's been many decades for most of us since we've been students, right? So we may have forgotten how to be a student, but actually committing oneself to learn something new can really be helpful. That's one thing. We talk about diet a lot. The average American diet is not particularly brain protective. There's good evidence that diets more like the so-called Mediterranean diet or the MIND diet, or diets which de-emphasize red meat and emphasize vegetables, fish, chicken, things like that, are better for the brain. So what's good for the heart is good for the brain. And then we also know that physical exercise is definitely brain beneficial. In fact, I told you earlier that I was reviewing grants today for the the Department of Veterans Affairs, and many of those were focused on exercise as a way to improve brain function. So we know that physical exercise and physical fitness seems to have the best evidence base for improving brain function, and it probably does that by actually inducing the body to secrete chemicals that are beneficial for the brain. So challenging the brain, taking care of one's diet, and physical exercise are three of the best lifestyle interventions that I know of that will contribute to long life and brain health. There are others as well, but those three are particularly important.
So a sedentary life is detrimental not only to your body but to your mind.
That's exactly right.
Go ahead.
No, I was going to say that I have had the good fortune of chairing a safety committee for a national study on exercise for seniors, and those folks are now being followed up for over 5 years. They took a group of sedentary seniors and then trained them in aerobic exercise, weight training, and they're going to follow these folks over many years to look at the impact, even in people that don't have dementia. What is the impact long term of improving physical exercise on brain structure and function? So that'll be exciting.
I know firsthand about the physical side of this, having been a football coach, track coach, and watching people who grew up with me allowing themselves at my age, old age of 75, to be so sedentary as to be unable to move about. So the sedentary life then says that the agility of the brain is
Changing.
suffering
That's right.
while your body is suffering.
But it turns out that those are the people that get the most benefit from learning to do exercise again. So it's the people that are the most sedentary that get the biggest bump in improvements, both in physical status and in mental status. So I would not discourage all your sedentary friends at all, because they're the folks that are going to get the biggest benefit. The benefit is always best at the far end. Even a little improvement in physical activity and physical exercise will produce a much more dramatic benefit for that person than someone who's already pretty physically active and physical fit. If you improve them, they're not going to get a huge benefit. But someone at the far end is going to get a big benefit. So we were talking today on our national committee about a VA program called GeroFit, which is focused on improving physical activities for homebound seniors. And they've had a lot of success over there at the VA with the GeroFit program, and this proposal was really to try to do this with telemedicine and really bring it right to the patient's home so they don't have to travel to the VA hospital to participate in GeroFit. So that, I think we're kind of at a new age of being able to bring those kind of benefits to people rather than making people come to us. And we're working on ways to do that as well.
I know that the Black and Brown communities suffer greater from issues of inactivity than any other group in this country. And the study and the groups that you have would be beneficial to an amazing number of people right here in this community. How do the folks that we attract, how do they get to the point of being a part of that study? I am a part of a study that goes on at the University of Alabama, Birmingham, on strokes, especially in people of color in the South. And theirs has grown immensely over I've been with them almost 20 years.
I see.
And as I hear you talking about approaching grants for that particular effort, it sounds like it might be something really good for someone who aspires to make that happen in those communities.
So you touch on a very sensitive and important topic, which is how do we bring these studies to what we call underrepresented communities, right? That's the term a term of art that's used in our research community. To how do we involve folks who traditionally have not participated in these types of programs? And so we are working. This is a problem for the entire field, I have to tell you. So, for example, in this study that they used to approve this new Alzheimer's drug, the company sheepishly admitted that their proportion of underrepresented Black and Brown communities was very poor. And they would be the first to admit that. And we, as a field, have done a lousy job over the years in making sure that we have equity in the representation of people in these studies. And so this is, the NIH has kind of put a gun to our head and said, you have to do more than you've been doing to enroll people who are make our studies representative of their communities. And so we here at the Center for Cognitive Medicine and at the Vanderbilt ADRC, Alzheimer's Disease Research Center, have really committed ourselves to doing this. And the way we do this is we build relationships with people such as yourself and the African American community here in Middle Tennessee. We are hiring and employing community liaisons like Blake Wilson, who's standing over here on the other side of the camera, to help us build bridges and relationships to communities that have not traditionally participated with us in medical research studies, because we can't just sort of hang a sign out there and say, oh, come one, come all. That's not going to work.
No, it isn't.
That's not going to work. And so we have to learn from people such as yourself how best that we can communicate with these relevant communities, and how can we develop a sense of trust and a sense of responsibility and a sense of there's something for both sides in all of this. And that's what we're working on doing. I'm not saying we're there yet, but we're working hard to get there. And I'm committed to listening.
We have a friend who works with the Vanderbilt Memory and Alzheimer's Project, Ms. Pam Cowley, and we've had one of the physicians in that area, Dr. Gifford, to interview with us. Ms. Cowley has since then entered into an agreement with the Northwest YMCA to make presentations on Alzheimer's, and she's coming to my church hopefully shortly, Metropolitan Interdenominational Church, to make that same pitch. And I invite this young lady to do the same, just as we sit here now. But the prevailing wind in the black and brown communities is that they are, what's the word? They are a little skittish about dealing with pilot programs because of, you know, the history of that, I'm sure. So what is it we can do for you that would help you at all on this and on behalf of our community in North Nashville and all of the surrounding black and brown communities in the city?
Well, I think the first way we can all be helpful to each other is education, right? So I've been spending much of my career focused on trying to convince physicians and people in the community that memory loss is not a normal part of aging. Gray hair is normal. Creaky joints are normal. Not desirable, but normal. But memory loss shouldn't be considered normal anymore. Maybe 50 years ago we would have considered it normal, but we understand now that it's a pathologic condition. And so we shouldn't be allowing our seniors to see memory loss as just inevitable. We have a lot of tools, a lot of ways to diagnose that just didn't exist even 10, 15 years ago. I've been in this business since the mid-1980s, and it's just been a revolution of science and technology since then. I mean, when I started out as a postdoctoral fellow at the National Institutes of Health in 1984, I mean, we were just grappling, we were in the dark. We were just trying to understand the basics of what we were doing. We didn't really even understand this disease at all. And we've made so many advances. Now, have we solved it? By no means. You know, it'll take decades and decades to really crack this. But we've come a long way. So we want to convey the message to all of our communities, both overrepresented and underrepresented communities, that we should not accept memory loss as normal. So that's step one, is educating. The second part is that we have so much we can offer now. We can make a lot of difference in people's lives. And then the third issue is that this is a partnership. We're partners together. I've always said to all of my research and treatment participants that we are partners together. I learn from you, and you learn a little bit from me, and we learn together. And so I like to think of my participants in research studies as kind of citizen scientists who work with us, not for us. They work with us. So it's a definite one-to-one partnership. And so I think that's another thing we can convey, and maybe you can help us convey to these communities, that we're in it to win it.
Only way to do it.
That's right.
I think I will have to make a commitment to become a part of your study for that purpose. If there is one specific thing you would like for our viewers to remember about this discussion, tell us, what would that be?
Well, many years ago, a woman and I were developing our first campaign about memory loss. And I came up with the phrase, "Don't forget your memory." And what I meant by that was, don't forget about that your memory is important too. You check your blood pressure, you have your cholesterol measured, you get your heart checked. Don't forget about having your memory checked too. And so what we encourage people to do is, if they have a loved one who is beginning to show early signs of memory loss, don't let that go. Call us. We can help with free memory screenings. We can offer ways to get things assessed. Is it a real problem? Is it just medications we need to take care of? Is there an underlying problem that we need to address? And so my message would be, don't forget about your memory or your loved one's memory. That we should be, just like you would if your loved one was clutching her chest because she was having heart pain, you would be concerned. If she's becoming forgetful, you should also be concerned.
Telephone numbers, contact information that our viewers can utilize to get in touch with your office and those who are supportive of your research, is what this young lady is preparing for.
That's
for me
right.
to
She's writing
utilize.
She's writing it down for me to.
What's your name again? What's her name?
Blake.
The number is 615-936-4997. 615-936-4997. Vanderbilt.org/
VUMC.org. VUMC.org.
Okay, that'll work. I'm going to leave that alone because I can't read it. But you said it. Ladies and gentlemen, we have had a nice discussion with Dr. Paul Newhouse about memory loss, dementia, Alzheimer's. He's given you some really significant information and ways that you can utilize to reduce or extend your memory, if not completely get rid of it. So your memory loss, rather. So we will say thank you very much for watching, and this has been Let's Talk About It. Have a good evening.